Hello and welcome to this legacy interview with Dr. Francine Conway, an outstanding clinician who's won awards and accolades for rethinking how we treat children with ADHD. She's been described as a rare combination of outstanding clinician, a smart administrator, and campaigning advocate for children. As Chancellor Provost of Rutgers University, she's been bringing to our attention the inequalities suffered by children of colour while applying rigour and research to their therapeutic treatment. We'll be inviting Dr. Conway to share her findings about these issues, and we'll also ask her why those of us who are passionate about children's well-being should be driving social change and making themselves more representative of the people we serve. I'm Jane O'Rourke, a child and family psychotherapist and the founder of Mind in Mind, and it's my great pleasure to be doing this interview with Salam Solomon. Salam is Director of the Centre for Prevention and Early Trauma Treatment at the National Service Office for the Nurse Family Partnership and Child First. She's also a board member of the American Psychological Association's Division 39, Section 2. Thanks for being with me today, Salam. I think we're both really pleased to have this opportunity for Francine to share her enormous knowledge and wisdom with us.
Yeah, I'm glad to be here. As I was saying earlier, when people were coming on, it's serendipitous that it happens to be the beginning of Black History Month today in the US, and also that we happen to be interviewing such an exceptional group of clinicians and administrators, Francine, but also her colleagues that will be joining her today. And so we're thrilled to have her. And we're really thankful to all of you who have given up 2 hours of your busy days to be with us today. So we're looking forward to digging deeper and really informing a wide range of professionals working with children and families about kind of cutting edge research and application to that research in the real world. So we're looking forward to that.
Thanks so much. Thank you, Francine. Thanks so much, Salam. Yeah, as Salam just said, we ask our legacy interviewees to choose colleagues to join with them to discuss their work. First, Salam and I will be in conversation with Francine, and then for the second half of this interview, Francine has chosen 3 guests to join her who are held in the highest regard for their contribution to the mental health and well-being of children. Dr. Kirkland Vaughan is a clinical psychologist and psychoanalyst. This wise clinician with many decades of work engaging with marginalised young people and their families in New York has been an important mentor and teacher to Francine and has deeply influenced her thinking and work. Thanks for joining us, Kirkland. We're looking forward to talking with you later. Dr. Nancy Boyd Franklin is a much respected professor of psychology and was named Distinguished Psychologist of the Year by the Association of Black Psychologists and has been an important influence too on Francine's thinking. They'll be in conversation discussing their passion for changing the therapeutic treatment of children of colour and their families. Thanks so much for being with us, Nancy. And Professor Karen Ensink is a clinical psychologist and director of Mentalisation-Based Treatment Canada. She'll be discussing with us her and Francine's pioneering work using mentalisation for children with ADHD. Thanks so much for joining us too, Karen. And we're allowing time in the last 20 minutes or so for your questions and tributes to Francine and her work. We very, very much want to hear from you, especially if you're here to integrate Francine's thinking into your work. And we'd love to hear about your experiences too. So please do use the chat function and we promise to keep an eye on it and keep coming back to it. And so to our legacy interviewee, Dr. Francine Conway. How does it feel to be with us today, Francine, celebrating you and your work?
Thank you so much for having me. I am deeply honored, moved for this recognition. And thank you and Salam for your vision to do this. I think it's really important that we are able to talk about these topics, especially given the times that we're in. So I'm passionate about children, and so I'm very excited to be able to talk about this work.
Yeah. So during our heady rise to the heights of Chancellor Provost at Rutgers, you've gained much respect and interest for your commitment to driving change in the field of child mental health, particularly in the treatment of ADHD. And you've utilised your position of authority to speak out on social and racial issues that particularly affect the therapeutic treatment of children of colour and their families. You've written widely on the emotional lives of children, and for some time you've been the research editor of the Journal of Infant, Child and Adolescent Psychotherapy. Yet your achievements are all the more remarkable given your childhood growing up in Guyana in South America. So let's step back a little to that time. How do you think those early experiences shaped who you are today?
Wow. Thank you for asking that question. First and foremost, it does shape not only my professional life in working with children, but also as, an academic leader in higher education. Belonging has always been a theme and something that I've chased. Part of it being an immigrant to this country, part of it being in the body that I'm in, a Black woman, always looking for places to belong. And I'd like to say that my passion for learning came at a very early age. At the time, I was raised by my grandmother, and I wanted to go to school. And my cousins who were older than me were getting ready to start the school year. And I was told that, there's no room for you. And besides, you're too young. And so my grandmother, bless her heart, is such a strong advocate for me and for children all over. She went and had a conversation with the teacher and said, look, what can I do to make her come? She's really eager and wants to be here. And back then, I remember schools were held in the bottom of houses, and it was open door. There were no walls. And so we call it bottom house school. So the teacher said to my grandmother, well, if you can bring her a seat, she can come. And so my grandmother literally built me a bench, which I walked to school every day, taking my bench back and forth. And that started my journey in terms of education. And really, I wanted to belong. I wanted to be there, and she made it happen. And so if I can be that bench for others, to provide access to education, to provide opportunity, that's what I want to do, it's paying it forward.
So your grandma was a huge influence in your life.
Oh, definitely. Definitely.
And so, maybe just give us a little sort of a short few sentences on your journey to becoming Chancellor Provost, because it's been quite a meteoric rise.
Yes, well, I came to
the gap a little.
Yeah, well, I came to Rutgers in 2016 as Dean of the Graduate School for Applied and Professional Psychology. And I found that we call it GAZAP, that's the acronym, really aligned with my values. A strong commitment to diversity, strong commitment to understanding the context of the clients that we're working with, the training that we provide to students. And I just really enjoyed that job. And then I was asked to be the provost of the campus. We got a new president, Dr. Jonathan Holloway, first African-American president of Rutgers University in its over 250-year history. And he asked me to serve as Chancellor Provost, and I'm really excited about his vision. I've been very blessed in my career to be in places where my values align with the leadership. And so Jonathan talks a lot about the beloved community, and that's his aspiration for Rutgers. And that really resonates with me because for me, a beloved community is a community where you belong, where it's not just come here and be here, but we're not going to sort of welcome you. It's, like I said, I often use the phrase, it's not just going to the dance, but it's also being asked to dance and being asked to be on the dance floor. And that's what I hope to create for students, for faculty, for staff. And it just aligns very nicely with my values. So I'm delighted to be in this role.
Yeah, well, you're more than dancing. You're leading the dance, aren't you, Francine? Now let's just let's just say that. You've written a number of publications about ADHD, and I think it's what you've become most known for, including this book, Cultivating Compassion. It's a psychodynamic understanding of ADHD, attention deficit hyperactivity disorder. And your TED Talk about ADHD has been seen by a lot of people. Why were you drawn to this condition?
Thank you so much for asking that question. This is a topic that's very personal to me. Prior to studying ADHD, I was working on aging. I was studying aging, grandparenting, and that kind of a thing. But I was trained as a child psychologist, and I'll talk a little bit about that later when we get to speak with Kirkland. And my own son was struggling with ADHD, and I'll just preempt this by saying I don't believe in ADHD. So even though I write about ADHD and I talk about it and do research about it, I don't really believe in ADHD. I think there's so many things that can lead to ADHD-like symptoms, and focusing on the behavior, focusing on the child's executive functioning only really just limits the scope of who children are and the depth of their experience. And I'm just going to share with you a quote from one of Maya Angelou's collection, Letter to My Daughter. She writes an essay called Home. And she says, one can never leave home, that she believes that one carries the shadows, the dreams, the fears, and the dragons of home under one's skin. So home is that youthful region where a child is the only real living inhabitant. Parents, siblings, and neighbors are mysterious apparitions who come and go and do strange, unfathomable things in and around the child, the region's only enfranchised citizen. And so this idea of centering the child and understanding that it's not just about doing homework, it's not just about finishing a task, but that there's more going on in the child. There's a lot of creativity and imagination, their interpretation of the world, and the adults that circle around them and move back and forth in and out of their lives. These things all impact the child. And when a child comes into my office, I see them carrying the weight of society, the weight of their families. This is all part and parcel. So when I say don't believe in ADHD, it's that it's not just simply a behavioral disorder, that there's more going on. There's a lot more to it. And so as I was struggling to understand my son, I was very embarrassed. I was ashamed. I felt like a failure. Like I'm a psychologist. I should be able to, and a child psychologist, no doubt. What kind of competent psychologist am I? I can't get this child to do anything. And I remember meeting with his teachers and just feeling, just crying, because despite my best efforts of organizing him, color coding his binder, making sure he has it as he leaves the car, somewhere between the car and the school, it just disappears mysteriously. And I just felt that the teachers didn't really believe me. I was concerned about, what they thought of him and his challenges. And so I was really, really frustrated. So I just started doing some research about it. And even in my own clinical practice, doing very behavioral types of things just didn't work. Parents never remember to do the homework. The child didn't remember. It was just too much going on. And so I said, there must be a different way. And so I went back to my psychodynamic roots and began to look at ADHD through a different lens. So that's what brought me, long story of what brought me to this work.
Yeah. And it's interesting what you say about ADHD, that you're not believing in it. But I ran a poll on Twitter yesterday asking clinicians whether they're getting more referrals for ADHD from parents and schools and what have you. And every single one said yes. So there's this perception of more prevalence. And I know in America it's the most frequently diagnosed disorder in children and adolescents. Why do you think that is?
Well, I think you're right. I think ADHD, there's a lot more education about it. There's a lot more parents trying to get answers. Folks are taking their children more to seek professional help. One of the things that I noticed, which sort of was disheartening to me, is that parents usually start with the psychiatrist. And after several attempts, medication it works to some extent, but then, they're expecting symptom amelioration, that it'll just disappear, it'll just go away. And when they hit that wall of frustration and they realize that, when the medication wears off, the child is back to doing what they're doing, somehow they find their way to a psychologist or social worker or nurse practitioner who has, training in psychotherapy. And what I realized from my own clinical practice is that ADHD is multiply determined. There's so many avenues and pathways that can lead to exactly the same symptom, cluster of symptoms. So anxiety, depression, trauma, learning difficulties, problems at home. And yes, there are children who have neurological insults in terms of their brain chemistry and how their brain functions. But many children have been just reacting in a very appropriate way to their environments. And, if a child is being maltreated, or if a child has experienced trauma or has depression and anxiety, I wouldn't want them to be acting like nothing has happened. We expect that they will be agitated, that they will have difficulty focusing. And what I felt is that a lot of the literature out there and a lot of the research that was being done never really emphasized a psychoanalytic perspective or a psychodynamic perspective. And we know that this point of view really gets at these underlying concerns that show up. And so it's the behavior, to me, it's just an indication of, hey, something's going on, someone pay attention to me. And then we get an opportunity to respond. So it really goes, I believe that a psychodynamic approach really goes beyond manifest symptom reduction. It's not about just reducing the symptoms.
Yeah. So in 2012, you published Psychodynamic Therapy of ADHD. It was a review of the literature of the evidence that long-term psychotherapy has a better success rate than conventional treatment, which is medication and behavioral therapy. Can you say a little bit more about that? What does that involve, the long-term psychotherapy?
Yes. I will say this, and certainly the literature has been updated since then. Psychodynamic psychotherapy has been proven to work with children who have incidences of depression, occurrence of anxiety. It's very effective as CBT. And what I understood from reading about some of my colleagues in the field is that there's a way of honoring the individuality of the child, that you're not trying to put them in a box or even pretend or presume to know what is going on, but there's this openness to really understanding the child. And because of that lens that psychodynamic psychotherapy brings, it really opened up the possibilities of, what is going on here? Is it really neurological disorder? Is it something environmental? Is it something within the constitution of the child and how they're just idiosyncratic in the way they view the world? So I really found that was a really good approach that sort of encompasses sort of a broader spectrum of the way ADHD presents itself.
Yeah. So the link you're making is is the link between the environment a child's in and the child's inner world. And of course, we don't need to be psychodynamically trained. You know, for those of us who perhaps might be in different professions joining us today, this is a sort of a conceptualization that everyone can benefit from if they are trying to help children with ADHD. Wouldn't you say?
Yes, I agree. You know, a lot of my work now in this, I have an ADHD compassion project happening at the ongoing project at Rutgers University in the ZAP. And what we're doing in that project is really focusing on the relational world of the child. So we're looking at behaviors are important, and we want symptom amelioration. We want, you know, the child to be able to function and have a, you know, positive experience of themselves. But what ADHD does is that it disrupts relationships. So the child is not able to have satisfying relationships with their peers, with their parents, with their siblings, with their teachers. Teachers really care and they want to help the child and they do their very best. And it could be very demoralizing when, despite your best efforts, whether you're a teacher or a parent, that the child's behaviors persist. And so this idea of thinking about, okay, so what helps with self-regulation? One of the things that helps with us having the capacity to regulate our behavior is the capacity to self-reflect. And it's almost like putting a pause between what your thoughts are and the action. This capacity to really self-reflect is crucial. It helps us to understand. It transforms our behavior. It helps us to understand what is going on here. And this is a natural capacity in some individuals, right? We can look at your face and say, you look interested. We can look at someone else's face and see, oh, they look sad or they look, distressed in some way. So with ADHD children, that capacity to take the perspective of others is what interferes with their ability to develop and maintain relationships. I remember once working with a client, a little boy, who came in to the session and he says, my friend, he just stopped talking to me. I said, well, why do you think that is? Oh, I have no idea. I don't know. He just stopped talking to me for no reason. And right there, I mean, clearly something happened, right, between when they were communicating and they had an established relationship and when the relationship fell apart. But for the ADHD child, the way their brain works, they could not take the perspective of the friend. And so part of the therapy is developing this reflective capacity, this capacity for reflection in the child, in the parents or teachers or whomever is working with the child, so that they can do what we call mentalize. Mentalization is the ability to really understand not only one's own mental states, but the mental states of others. And it's this understanding that allows us to think about intention. It allows us to have the appropriate affect. And one of the challenges in ADHD is that the affect regulation becomes is sort of impaired. And so we result in hyperactivity, impulsivity, sort of the child not practicing at the sort of capacity, building the capacity to self-reflect. And, a lot of times the ADHD child would say, a lot of my clients, they would say, oh, I was just bored. And that is, boredom is not an emotion. But for the ADHD child, that's how they experience themselves and experience themselves in a lot of different contexts. And so, how do we broaden that and give them a broader range of experiences and emotions? And that all leads to being able to self-regulate.
Yeah. And I know that the concept of empathy is central to your work as well, that goes alongside this mentalization-based treatment. And we're going to be hearing from Karen Ensink about your work together on a mentalization-based treatment for for ADHD, children with ADHD. And you just described brain research that suggests that there might be deficits in areas of the brain associated with empathy in some children with ADHD. And of course, that part of the brain is also linked with self-regulation, which concurs with what you've just been saying about the importance of self-regulation in ADHD.
Yeah, and we need to do more research about that. But what we've found in the neurological research, at least that I've looked at, is that ADHD points to deficits in the brain, in several areas of the brain that are parallel and associated with an empathy deficit. And so, I've gotten into trouble for saying that there's an empathy deficit in ADHD. And I don't think, it's not that ADHD children aren't loving and kind and can't feel emotions. They can. But another part of empathy is perspective taking. And to be able to be empathic, you have to be able to take the perspective of others. And that's the area where, some of the brain science, what it shows is that regions of the brain responsible for self-regulation are also responsible for empathy. And when I read that, it really sparked something in me because until that moment, I hadn't realized that the very areas of the brain that are responsible for executive functioning, for self-control, for emotion regulation, reading emotional expressions, those are the areas that are problematic or that have some impingements in the few studies that were done about the brain. So we're looking at like the amygdala, which is responsible for regulating emotional learning and reading emotional expression. Areas of the brain like the anterior cingulate cortex, which is activated during observed and experienced pain of self and others. And then we have the anterior insula, which is responsible for one's pain and the pain of a loved one. And so in the neuroscientists that were conducting research on ADHD, they found that deficits in these regions of the brain also led to ADHD symptoms of impulsivity, poor impulse control, and things like that.
And of course, for some people with ADHD, that might come as a relief that some of these things show up on brain imaging. But I'm thinking, for parents with a child with ADHD, they might be feeling really very responsible and that they've done something wrong, which I think probably you can relate to as a parent yourself, of a child with ADHD.
Yes, definitely. I think parents are naturally prone to feeling guilty and sort of beating themselves up. And, despite their best efforts, the child their behaviors don't change. And so one of the things that we try to do in the Compassion Project is really work with the parents as well. So it's not just the child, but it's with the parents to help them understand the inner life of the child. And I can't tell you how many times parents seem surprised when I say to them, in a couple of cases I can think of, your child is suffering from anxiety and depression, and they're completely surprised. It just never occurred to them that this little person, and that they might be struggling with their own emotions about things. And one of the sort of, not side effects, but the sort of problematic result and association to ADHD is that when you've tried to do things and you're unsuccessful repeatedly, time after time after time, eventually you begin to believe that you're not capable. And this leads to the depression that I mentioned, the anxiety, poor self-esteem in the children. And so we can't just simply focus on the behaviors. We have to consider the impact of these executive functioning deficits on the child and on their emotions, and really consider the inner life of the child, the inner experience of the child. And that's what my work is all about. It's not saying you can't take medication. It's not saying you shouldn't do CBT or other kinds of therapies. What I'm saying is when we don't address the underlying emotions of the child, when we don't pay attention to the child's own experience of themselves and of others, then we're not really addressing the whole problem. We're just focusing on part of it.
Thanks, Francine. I'm going to be handing over now to Salam, who's going to get into some of the depths of clinical treatment and speak to you about that, so you can have a good case example to illustrate your work.
Thanks, Jane. And thanks, Francine. One of the things that you said when we were preparing that really stuck with me was this issue around the empathy issue is not just in the child, but in all of us too, towards the child, right? Like we all, or at least I have often felt very frustrated working with children with ADHD because they just don't do what you want them to be doing, and so this kind of this general empathy deficit all around. I wondered if you can demonstrate that to us through a use of a case example. If you can briefly describe a case. I think you mentioned Jason. I don't.
Yes.
Work with Jason.
Yes, I actually wrote about this child, and really from the perspective of when we think psychodynamically or psychoanalytically, we're thinking about transference, right? That's a common dynamic in any therapy case. And so this child really stuck with me, actually, because his early caregiving relationships were really turbulent. His own parent was not available. His mom was, using substance. His aunt, who became his caregiver, had several serious medical debilitating issues going on, and around cancer, and needed brain surgery and things like that. And so when he came to me, say all the traditional presentation, disorganized, difficulty planning, focusing, paying attention, so on and so forth. And that first couple of sessions with the child, and even with the students that I work with right now, who are just amazing, my doctoral students at Gazette, they see this idealized transference. They see the child really, being very good, sitting perfectly still, just being a perfect little angel. And they often say, the parents are complaining, but I don't see the challenge. This child works well for me. And I really caution students, because I say, parents are not the enemies. They're bringing the child, which means that they're concerned and they want to get some help. So let's not start villainizing the parents and pathologizing the parents, that this is just the sort of early relationship idealism. So moving forward in the treatment, this kid, I'm calling him Jason, he would just come into my office and just destroy it. Just toys everywhere, just flipping things, whatever he could flip. I'm constantly having to put the reminders of, we have to be safe, and, he's turning on and off the lights. Just a disaster. I always need to put a lot of time in between him and the other clients to fix my office back. So one day he comes in and he's trashing the place, and I says, there's a lot of stuff flying everywhere. And he says, yeah, it's all trash. And I say, well, I guess it's a trashing day today. And then he says, yeah, it's all garbage. It's all trash. Okay, now you pick up the trash. And he said, oh, I'm the garbage person. I have to pick up all the trash. So I start picking up the trash and putting it back in the bin, the toys putting it back in the bin. He messes it up again. And so we do this cycle of, and he has this metaphor. And when I talk to Karen, we talk about Karen Ensink and Nick Midgie and colleagues talk about this focus formulation, which is like coming up with a metaphor that the child identifies with. And for this child, it was, superhero. He was superhero. And so we use that formulation to find moments when the superhero isn't flying around, or the superhero isn't bending steel, right? This is the sort of hyperactive side of the child. The times when does the superhero sleep? Does the superhero eat? right? So kind of expanding their view of themselves and also using it with the parents to say, hey, this child isn't always hyper, isn't always failing. There are other experiences of this child. Anyway, so back to the session. So, he says, yeah, you come, you clean up, you're the superhero, but you're not doing it right. And so when we finally go through a series of these dialoguing, come to find out he had a really quote unquote garbage day at school. So, well, what happened? Well, I wanted to go to the bathroom. Teacher wouldn't let me go to the bathroom. I really, really had to go. Otherwise, I would have an accident. And he just walked out the classroom. And of course, when he came back, he was in trouble and he had to go to the principal's office. So, the point is that there are ways in which this child can really demonstrate in the treatment in a very symbolic way what their inner experience of things are like. And so one of the things that my students experience as they move through, so when we go from this idealized state to sort of this next stage of the treatment, and the child is really demonstrating all these behaviors, they do feel like they're failing. They do feel like they're not doing it right. And sometimes in the supervisory relationship, it becomes, you're not giving me everything that I need to help this child, right? So it's like this parallel process. And what I try to tell my students and parents and myself is that child is eliciting in you, and in a very skillful way, projecting into you their own experience of the world, that they feel helpless, they feel ineffective, they feel that they can't get things done or things don't go the right way. And that's a dynamic we all have to sort of look out for. And if we allow ourselves to go down that path and see the child in that way only, as opposed to a spectrum of behaviors, we will give up. And I know that there's some times when some psychodynamic oriented therapists don't want to see these kids because they're too disruptive and they don't make you feel like a good therapist because, these behaviors are so problematic and prevalent. So
I so appreciate this perspective, this kind of projective identification perspective, which is really applicable across all of us working with young children, right? If we all pause and think about what is this child generating in us, whether we're a nurse or a care coordinator or a teacher or any other profession, this idea about enhancing our own reflections about what is this child generating within us and what does that tell us about how this child is experiencing the world can really help us with our own empathy developments, right, for this child and the child's needs. And I also really love the idea of finding a focus. I think it's a focus formulation. And I in my experience, I've had a lot of children that really identify with Hulk. And Hulk is such a great superhero because usually he's like a good guy, right? But then something happens and then he turns into this scary monster, right? And so it's a lovely way to help children identify with themselves in a way that is helpful to them. The other thing, Francine, that you spoke a bit about that I'd like to highlight, particularly because it's February, is this idea about that our response to the behavior of children with ADHD is different dependent on their postcode or zip code in the US. Can you expand on this a little bit more, please?
Yes, I'm happy to. First of all, ADHD is more prevalent in males than females. And I apologize for the binary kind of distinction there. We also have in our clinic experience or worked with ADHD children that were non-binary. So I just want to put that out there. So with boys or males in particular, African-American males, and there are different responses to the ADHD, right? So if you're from a more higher economic bracket, and which means parents have more resources. You're probably in a, quote unquote, upwardly mobile or upper socioeconomic neighborhoods, so on and so forth. The approach to the ADHD is very different. We're looking at, a framing of the child's difficulties as they're twice gifted or twice exceptional, which means they have a learning challenge as well as these behavioral or emotional dysregulatory kinds of experiences. But ADHD is also clustered with conduct disorder and oppositional defiant disorder. And for African American boys in particular, that's where they get the sort of, that's the interpretation of their behavior. So it's, no, not that you're exceptional or gifted or artistic even. It's your conduct disorder, your oppositional. And that distinction and the way in which boys get categorized is very problematic for me. It's very problematic. And I do believe that it's because of their race and, that they're perceived in such a negative way.
Thank you, Francine. And I'm sure you and Kirkland will expand on that when you speak in a little bit. We do have many nurses with us, as well as care coordinators, teachers, social workers, and many people working with children, young children in particular. What practical advice would you have for parents that they're working with? What are the ways that they can be helpful?
Yeah, so with parents, thank you for listing the different professions that are here. And one of the things that I realize is with ADHD, the medical interface is kind of like the first stop. Nurses notice these behaviors, may bring it to the attention of the parent. Other medical professionals may bring it to the attention of the parent. And I'll say a couple of things. One is that if you can find a way to sort of help the parent to see that this is not just about the behavior, to kind of open up that, give some space, give some reframing of the child, it could be very helpful. One of the things that's documented in the literature is that ADHD kids are more likely to experience maltreatment and abuse. And I think it's in part because of the frustration. If you're a parent and your mindset is, I'm trying to get this kid to do this thing and they're not doing it, and I know they can do it, that's what I normally hear, some kids do get hit. And we've had situations where we've had to report, abuse or neglect or some kind of maltreatment. And so if we can just think about the parent's perspective a little bit. So we're saying, apply that same mentalizing approach to working with the parent, to really expand their view of the child. I would say to the parents, the world is going to beat up your child. This child is going to have a lot of challenges. You don't want to add to it. You don't want to be one of the others who's, adding to the pile-on. So how can we help our parents to become advocates for their children? How can we as teachers, nurses, professionals be an advocate for the child, and just see what they're presenting as a little broader and a little bit more complex than simply behavioral problems. And the last thing I'll say is that I often use metaphors with my parents and with teachers. One of the metaphors I use is the metaphor of a wheelchair, that you give your child a wheelchair and you roll them into the building up the ramp, and they're great. They're access the building. You do this like 10 times. What happens with us, all of us, is that the 11th time we remove the ramp and we say, okay, go on into the building. I know you can do it. You've done it before. And that's really the absurdity of what we do. We're not intentional about it, but that's in effect what we're saying. And the second metaphor that I use for parents is one of Swiss cheese. when parents say, you know, I've seen him do this before. He can pay attention when he wants to. Yes, he can. But if you imagine the image of a Swiss cheese, there are holes, there are gaps in the child's ability and functioning. It's inconsistent. And that's where we want to remind parents that although you saw this ability or this capacity emerge in this context, it doesn't mean that it exists across the board.
Thank you, Francine. I think these are really great and practical ways that we can be helpful in our work with the parents. We're going to pass it over now to Kirkland. If there's opportunity at the end, there's one question that is kind of the motivator for me for a lot of this that I would like to get back to, which is this issue about what have you held on to from your psychodynamic training, and what are the things that you've discarded and feel like, you know what, that doesn't work for me. And I think maybe perhaps you and Kirkland might talk about that too, because he shared some of his thoughts about that when we spoke. So I'm going to hand it over to Jane, and we'll switch over to the second part of our interview now. Thank you so much.
Thanks. Welcome to Kirkland, Dr. Kirkland Bournes, who's a giant in his profession. He's a renowned clinical psychologist and psychoanalyst and a respected authority on intergenerational trauma among African Americans, in particular Black boys. Kirkland is a senior adjunct of the Derner School of Psychology at the Adelphi University in New York. Kirkland, you're joining us today because you've had a major role in Francine's life, teaching and mentoring her. Actually, it was very moving when we all got onto the call a little bit early just to do our sound checks. And Kirkland, you were there, and Karen and Nancy, and Francine, you had to sort of just stop for a moment, didn't you? You were really sort of quite emotional seeing some of these key people in your lives. You've told me, Kirkland, that you've come across few people in your career who've been as impressive as Francine in over 30 years of teaching, and that's quite an accolade to Francine, isn't it? Can you hear me, Kirkland?
I didn't hear a question.
Ah, okay. I said that you said to me when we were talking about Francine that you've come across few people who are as impressive as Francine in your career.
Absolutely. I started with Conway, as I call her, okay, when she became a doctoral student at Adelphi. And I was the director of a mental health clinic that focused primarily on children in East New York, Brooklyn. And she came when other folks were very reluctant to come into that clinic in the first place because of its geographical locale. And Francine voluntarily came, and I saw her talent and ability to work with children. So I wanted to focus in on that because there's so few, in my opinion, child therapists, number one, and extremely few people of color who are child therapists. So I thought she had something to deliver to the community of children who rarely got actual treatment. And then there was a question about the quality of the treatment that they were receiving. And so when I met her, I felt like, boy, here's a great opportunity, and I'm going to exploit it. And the rest is the history. We needed her very badly. And
well, I needed you too, Kirkland. As I was saying before, institutions of higher education are not always very welcoming places, and places where we see ourselves reflected in the faculty. And so when I met you, I was really appreciative of how what you created for me was a home. Like, the Maya Angelou essay that I quoted at the beginning, seeing you was like being home, and I could be myself. I felt safe, and I felt taken care of. And not to mention the fact that you're an excellent clinician and has really taught me well. And one of the ways in which you really shaped my work is really understanding how historical trauma can pass through the generations. And that when these young boys come to my office, it's not just, here's a behavioral problem. It's how they're viewed by society. It's how, whether or not they're given the benefit of the doubt. It's how people clutch their purses when they walk by. So all of that helps me in training my students and in my work as a clinician, to say, it's not just, here's a child who isn't listening to the teacher, or here's a child who isn't behaving properly, but that these contexts really matter.
Mm. And Kirkland, you say that you're worried about what happens to Black boys in particular around about grade 4, when their performance goes down, and you describe school being a prison pipeline for some of them.
School to prison pipeline.
Yeah.
Yes, except 20 years ago, it was the 4th grade. And that's when Black boys apparently appear to be little men to white society. You'll notice the Black boy who got killed by a police officer in Detroit. On his radio call, the boy was 11 years old. The police officer says, Black male down, 20 years old. The boy was 11. So that's a stark example of how they are adultified. And except it's changed now, and the change is even worse, because now African-American girls and boys are being suspended and expelled from pre-K at a higher rate than they were in the 4th grade 20 years ago. So it's dropped to pre-K and kindergarten and 1st and 2nd grade. Our system, our cultural system of oppression has become more intense even in the earlier years. So it more than concerns me. One of the things that I was also impressed about by Conway that I was not familiar with is your history with your grandmother. And I have felt in listening to you and knowing the work that you have done, that you carried that bench with you and set it down for other people to attend learning. And I so appreciate that about you. You're one of the things that you did at Adelphi that had a lasting effect was you started a mentoring program for young faculty of color who were just coming in. And that still is there in existence today and much, much needed. Your absence was felt by me, who's been there for 25 years, I would say as the 3rd most vacant spot in the Derner Institute since its inception. And I got there in 1977. So out of all the people who have left, you were the 3rd. Derner was the 1st when he died. Okay, and so when you left, a gaping hole was there for faculty and students of color as well. So it wasn't just faculty that your focus was on. I think that another very important thing that you did, this involves the mentor, i.e. me, becoming the mentoree of that person that he mentored. I felt like I was in class with you just now. I'm loving every moment of it. Okay. But what I think is also important was your book, and it was before your book got published. You're writing articles on this. The title of the book is Cultivating Compassion. So that is like a call to arms for us to recognize our shortcomings, not the shortcomings of the child patient. Right. Look at what the heck we're doing and not doing. And you were in the forefront of bringing ADHD children, quote unquote ADHD, okay? I respect your disagreement. We're saying that we want to help them clinically, but we have no compassion for them. So we then become a part of the problem, that without this compassion, Without, we then cannot honestly mentalize them, and that's what we're supposedly doing, is teaching them to mentalize, but we're actually teaching them that they can't mentalize because they can't be mentalized. So it's an absurd approach that existed, and I'm glad and proud of your forefront take on this.
Thank you, Kirkland. Thank you so much. I mean, I think the work that I did in the clinic with you, that early work, just really shaped my lens and my perspective, and really helping me to understand that it's not just what appears. I remember distinctly once there was a case that I was working on, and you were supervising me, and it was a young girl who had some difficulty with her caregiver, and I was young, and I was like, she is just so mean to the child, and we should report her. And I was really just very idealistic, and you really sat me down. I don't know if you remember this, and you explained to me the fear that the mom has, and not wanting her child to turn out a certain way, and just how that drives the passion and the intensity of her reaction. And with ADHD kids, I see this all the time, where the child's perceived failure or not living up to their potential becomes really fraught with all the cultural meaning and all what it means to be the Black man in America and to be successful. Like, that's what's on the table for these kids. So I really thank you for all the ways in which you've been there for me and said, hey, let's sit down and have a conversation. And I hope I can do that with my students as well. So
I see it that you are doing that very well. I wanted to emphasize another very critical point that you made. You talked about abuse being much more reported in the Black community vis-a-vis zip code, and I see that every day. One of the things that happens, if I have to take off from work just because I want to take off from work, I'm still paid. Okay, I can take off from my job when I had it 3 weeks without any financial repercussions whatsoever. If you are not well paid, and if you don't have that kind of financial protection, the teachers are calling you into the school, means you got to miss work. That's a meal that cannot be put on that table. In addition to that, your boss is saying, take off another day, you won't have a job.
That's right.
So the parent is set up when they enter the school to see the child in a particular way is now a threat. This can't go on. The parent is much more desperate, and this happens over and over and over. Teachers not being empathic with the parent, with the child. You're all at fault, and you got to fix this. So here's a whole institution dumping it right back. That's point one. The other point that I don't want to go missed is I'm very impressed with the array, the national array, the international folks who are here, as well as the whole spectrum of child care workers. There's a whole spectrum here, which is very impressive to me. But you also called not only our shortcomings on not being sufficiently compassionate or not compassionate at all, but psychology had reneged on its ethical and clinical standards and obligations to these children, and allowed psychiatry to take over and push the pills. And the pharmaceutical industry loved it. And so your push has brought it back into a psychodynamic frame for us to be able to begin to look at the child very differently, as well as our profession, and get out of the realm of clinical name calling with these kids. And I know there are times that in working with these kids, they have frustrated the living daylights out of me. A clock that I love, this kid just pushed it over and watched my clock hit the ground. And of course, he was frightened of me because he was able to be empathic with me. I wanted to kill him, But I was able to contain that, and then begin to talk with him about what pushed that. And very, very slowly, at first it was the denial. I didn't push anything. It fell over.
Yeah.
Gee, a lot of things are just happening here.
Well, Kirkland, what you just said is exactly the work, right? So that when I was talking about this kid who was trashing my office, he's expecting me to react the way everyone else in his life reacts, right? And so going through that sort of episodic kind of routine with the therapist over and over and over again and say, oh, wait a minute, there's a different response here. It begins to start to loosen up some of that, toxic sense of who they are, or that I'm bad, or that I'm evil. And really, you're providing that containment for the child. And the therapist has to sort of hold the child metaphorically in that space. And it's just a beautiful thing when you experience it with the client. And I remember one day, this kid came into my office, just sat down on the floor, crossed his legs, put his hands up and started humming like the Buddha. And it's like, oh, is this what we're doing now? It's like he went from trashing to, okay, but he was being charming and funny. But the point was well taken, which is, hey, look at me. I can actually sit and be still. Yeah.
That's great. That's a wonderful example.
Thank you for now, Kirkland. We'll come back to you. I'm going to be handing over to Salam now, who's going to be introducing Nancy Boyd Franklin.
Thanks, Jane and Kirkland and Francine. And Kirkland, I just love the look of pride that you're carrying throughout this whole interview. Just so pleased to see Francine.
Actually, Salam, you said something I thought was very interesting about Grandma's bench and what Kirkland might represent to Francine.
Yes, I did think that Kirkland also built a bench for Francine, and we all, I think, need someone. And I have someone right here on the call today that built a bench for me as well. And so I think we all need someone like that, and we will be talking with Nancy about that in a moment. So Nancy is a distinguished professor of psychology at the Graduate School of Applied and Professional Psychology at Rutgers University. She's the author of 7 books and numerous articles on the treatment of African American and other minority clients and families focused on ethnicity and family therapy. We're thrilled to have Dr. Boyd with us today. Francine, I'm just wondering, you've been very much also influenced by Francine's thinking, especially as it relates to issues of compassion. And I just want to invite you, the two of you, to maybe engage in a conversation around that. Nancy, are you here?
Thank you.
I see.
Francine, I think, like Kirkland, I was very struck in reading your work and in following it over the years. I don't believe there are accidents in life. And so I am not surprised to hear about your grandmother, since some of your early work in the field was actually done with Black grandparents who are raising another whole generation of kids. But I'm struck by your emphasis on compassion at all levels in your work. Compassion for the child with ADHD, compassion for the parents. And as a supervisor, what I was struck by today, I was hearing this also in Kirkland's comments. As a supervisor, you bring that compassion to helping your students or trainees to understand the inner world of not only these children, but in the case of parents of color, particularly Black parents, but I think all parents of color, the fears that we all hold for our children, particularly our sons. I do not think that it is accidental that boys are disproportionately diagnosed by society with ADHD. And I am very struck by how many Black and other boys of color have been diagnosed and misdiagnosed with ADHD. The other thing that struck me at the end of your discussion with Kirkland was this notion that Black parents in general, and by the way, I'm getting ready to give some talks in the UK. This is true in the UK too. It's not just the US. For Black parents, there is a fear for our children, all of our children, but particularly our sons. Fear that they will be labeled, fear, as Kirkland pointed out, of the school to prison pipeline. Black kids, particularly Black kids in inner city or low socioeconomic areas, are often treated as if they are conduct disordered from a very early age. And Kirkland mentioned the school to prison pipeline. And I think your work, Francine, with ADHD kids has the potential to impact not just parents, but schools and how we view these children. You and I have talked many times. We share the experience of having children who look much older than they are, particularly our sons, and teachers. And let me add, psychologists, therapists, nurses are often frightened of our kids as they grow. You know, when they're small and cute, that's one issue. But by second grade, third grade, a lot of our children are taller than the teacher. So when they're tall and cute, the kinds of fear that they evoke in others can be very, very powerful. And Fran, I'm hoping that your work on ADHD not only helps families and parents and teachers to be more compassionate toward our children, but also helps us to be more compassionate toward their parents and their families, because those fears are very, very real. I am just so proud of you and what you've done with this work, and the impact that you've had, not just on the therapeutic work with these children, but particularly for children of color, the impact you've had on us as practitioners in thinking about, well, what might be in mentalizing and understanding not just the child's experience, but the experience of the parents, the experience of the family members, the experience of the fear that racism causes for so many.
And Nancy, you, in your book, when you talked about raising boys into men and just the importance of family, the family system. I mean, I've been reading your work from when I was a social worker, actually, and up through the years. And it's so important. What I take away from you is not to lose that systems perspective, that kids are part of the family, right? And like which is why I love that essay so much by Maya Angelou. It's like, there are people coming in and out, they're part of this whole big system. And, for some kids, they're in the corner and no one notices them. For some kids, they're very much in the middle of it. And we can't discount that. We cannot discount that context. And also to understand the extent to which the family is so important for African American people. And it's such a big source of strength and renewal and all of that. And so when parents come in to the clinic and they're afraid, it's helping our students to see it's not that parent is angry or hostile or combative. It's they're afraid. They're afraid for their child and they do want it to be different and better. And so I really thank you for all that you've contributed to the field and how you lead the charge. And the other thing that I took from you, Nancy, is this commitment to diversity and inclusion. And I know at Rutgers you are so missed because you have led the charge for years, for decades. And you're such an advocate for Black and Brown students, for all students actually. But the Black and Brown students, we find the one faculty member or two faculty members who are faculty of color. And, one of the things that I'm really proud of with our current president at Rutgers is that he has this commitment to having the university, all levels of the university, mirror the society that we're living in, mirror the state that we're serving, because people need to find a place where they belong. And so you and Kirkland have been that for me, this sort of home away from home, or as Salam said, the bench that sort of connects. And so I want to thank you for all that you've done, to contribute to the field and for always keeping us oriented towards, the fact that it's broader than just here's a child and here's a symptom. And I remember once having a supervisor a long time ago who said, as psychodynamic practitioners, we don't have to work with the parents. We just take the child and we meet with the child and we work with the child. And it's like, how could you not talk to the parents? How could you not include them? And the grandma and the auntie, because we've had situations where, the caregiver, the parental person is grandma and aunt or cousin, and it's not mom and dad the way that traditional parents are structured. So yeah, I'm really happy that I got a chance to work with you and even to know you.
Yes, Francine. So the parent as an inconvenience, right, to the work that we have to do, and that of course can't be. I really appreciate the comment around the fear, not just in the parents, but in all of us in doing this work that often goes unacknowledged and therefore acted out and unprocessed. And I do think that's kind of a taboo issue, I think, and is one that I really appreciate you raising together. I wondered if you could also talk, you started talking about that a little bit, but what do you see your role as leaders in the field, as Black women? What do you see your role in terms of mentorship, advocacy, recruitment, retention of clinicians of color?
Oh, you've just hit on the heart of a lot of the work that Fran and I have both done throughout our careers. I told you, Salam, when we talked, that one of the things I'm hoping will come out of this is more of an understanding of the work that Fran has done to push our field and related fields. We are both psychologists, but these issues are as relevant for nurses and social workers and teachers, that we see social justice as a part of our work and social change as an essential part of our work. And Fran has advocated for that in every setting that she's been. As Kirkland said, she's greatly missed at Adelphi because that's the perspective she brought. And many of you are working with therapists of color who may feel very alone in your settings. And we think a lot about our clients of color, but it is really essential that we bring that compassion to mentoring, supporting, not just recruiting, but retaining and encouraging persons of color within our settings. And Fran has done that in her work. Fran has done that in her leadership. And in her role as dean, but now in her role as chancellor, she's got a bigger stage and more impact. And I'm hoping that each of you will not only use her work on mentalization to recognize the compassion you feel for children with ADHD and parents who are struggling with their fears for their children, but also to learn from your colleagues of color and to mentor colleagues of color to make it comfortable for them to be in our settings. Fran, I'm sure you have a lot to say about those issues. It's been an area of some of your greatest contributions.
I just want to add an amen to that, Nancy.
Yes, I was feeling it, Kirkland.
Yeah, absolutely. And Nancy, you have modeled that for me. I mean, working at Rutgers, I was saying before we all got on the call, I was sharing with Jane and Salam how, there were dark moments, right? Because I did not always feel a part of the institution. And in those moments, you would often come into my office, close the door and say, let me say a quick prayer for you, just to kind of boost you up a little bit. And that's the level of support that really a lot of us are going to need to give to our young students, faculty, staff, because it is isolating and we don't see ourselves as part of the institution. And so to the extent that I can help people to feel that they belong, I think is really important. At Rutgers, we have a lot of first-gen students. So it's not just Black and Brown students, it's also first-generation students. The first time they're coming to college, they don't have mommies and daddies who did. They're not socialized to, quote unquote, be a college student. And they need us. They need us to provide that scaffolding so that we can help. And so even though I'm an administrator, the way I think about my work is still very much through the clinical lens and how can we provide that scaffolding. And I'll just add that with COVID here, one of the things that I have said to the deans and the faculty and the students, it's like two things, compassion and flexibility. Compassion and flexibility. We never know what someone is dealing with. We never know. And it's not just okay to say everyone must march left or everyone must march right. And I think psychodynamic understanding helps me to understand the individual and the nuances and idiosyncratic ways in which we bring our own stuff to the table. And so to the extent that I can, as an administrator, sometimes I am seen as bad or have to make tough decisions, but I try to do it with as much compassion as I can. So,
and listening to you, like Kirkland, I am struck by how much you have brought your own culture and who you are to your work. And, in my own writing about Black clients and families and other clients of culture, we are collectivistic cultures. We believe in, there is an African saying, I am because you are. And that sense of us rather than I is a very important part of other cultures, of certainly of Black culture, but of many other people of color. And spirituality is a huge part of that support system, but it's something that our field has forced underground. Mm-hmm. And I'm hoping that this discussion will lead so many others to reach out to their colleagues of color and learn, but also to reach out to their colleagues of color and support them. You've done that and done that not just at Rutgers or Adelphi, but to colleagues of color throughout the field. And that is something very powerful, Fran. And I think that this honor and the award and the recognition that today represents is absolutely something that you deserve.
Thank you, Nancy, and thank you, Francine. And I think this comment around I am, because you are really is a shift in perspective for most of us. I'm going to shift over to having a brief conversation between Karen and Francine so we can leave time for questions at the end. And Dr.
Salam, can I just say, getting some comments from our audience today, just before you move on,
Yep.
Karen. Laura Dowse is saying, I'd just like to say what a wonderfully inspiring holistic discussion. It's rare to hear a conversation that has a space for the individual work, the family and social issues, and a focus on compassion for all. Thank you. Nancy, where can I find information about your talks in the UK? So maybe you can give us that information and we'll share it with everyone. And Rajinder is saying, thank you, Nancy, for that comment. It's totally isolating as a school counsellor anyway, but I work in a school where all the senior staff are white. It's not enough to have one or two people of colour to represent. Mentoring is essential to feel a sense of belonging. This is also picked up by the young Black people I work with, that there is a falseness where representation is concerned. So that's going to feed in, I think, into our wider discussion later. So if you've got any comments to make as the discussion progresses, we'll come back to you. We've got space at the end of today's interview. We'd really like to hear your comments, your experience. Does it resonate with what Francine, Kirkland, Karen and Nancy are talking about? So please do. And if you want to share any tributes about Francine, it'd be lovely to hear those too. Thanks, Alan.
Thanks, Jane. So Professor Karen Ensink is a clinical psychologist and director of Mentalization-Based Treatment Canada. Alongside colleagues at the Anna Freud Centre in London, she's developed mentalization-based treatment for children. She has also developed a measure for assessing mentalizing in young people called the Child-Adolescent Reflective Functioning Scale, which is widely used in many countries to assess the way children are able to mentalize about themselves and their attachment figure. Before we get into a conversation between the two of you, I think it would be helpful. I know, Francine, you defined mentalization a little bit earlier, but if you can just briefly, just really succinctly tell us what that is so that we are all on the same page. As you begin talking about the outcome study that you worked with Karen on in developing an effective intervention for improving psychological functioning in children with ADHD and to measure their mentalizing capacities.
Sure, thank you so much. And I am truly honored that Karen took the time to be here and do this with me. So mentalization is really the ability to understand one's own and others' mental state. So it's not just predicting or having a perspective about someone else's mental state. And this goes back to attachment literature and very early in development where, mommies mirror the faces of the babies and children learn to self-regulate through that sort of back and forth between the mother and the baby. So mentalization is sort of like at the point where you're working with the child and you're trying to understand and imagine what is in the mind of the child. And they in turn try to understand and imagine what's in your mind. And it's nice to see when that shift happens in the relationship, because at times it's just, the therapist really trying to understand and mentalize and connect with the child. And then at some point in the treatment, they start doing it back. And it is at that moment when the child learns to put a pause between thought and action that we see the impact of this kind of work. And Karen has graciously attended some of the didactic meetings that I have with the doctoral students that we're training. And I remember this one student was presenting on a gender, a non-binary child, actually. She's quite young. And we really were struggling with this case and really wanted a kind of a perspective on it. And so Karen came in, and not only this case, she's heard other cases too from within the clinic, the Compassion Project, but she was gracious enough to consult with us. And I remember, I don't know, Karen, if you remember this, but as you were talking and listening to this child who sort of, would come into the session and turn her back on the therapist and just not engage. And one of the things that our students like to do is to try to focus on content. And one of the shifts that I saw with the students is when you said, well, why don't we imagine together? When I do that and I crawl around on the couch, it's because I want to put things into words, because I'm afraid that someone might make a big deal out of it and just not think with me about it. And I think that was the nuance there, is that you want to think with the child about what is going on in the room. And so, Karen would say, what is it like for you? When I do this, what do you think? I think, my goodness, you've got so much going on inside of you. And this very empathic way that Karen has of sort of working and joining, I call it joining, sort of her mental state with what's going on in the child and trying to get them to make that connection, I think is pretty, pretty powerful.
Francine, just to respond, I think that we feel each other as clinicians, and that's why we drifted together, why we recognized each other as clinicians, and could speak that language together. I just want to say, when you explained what mentalizing is, I realized that in this group, we have Miriam Steele, and of course, she's one of the people who developed that idea. So I can't stay silent and not mention that when we talk about it. Francine, I think if I had known what an amazing, illustrious career history you had, I would have been too intimidated to work with you. So it's a good thing I didn't know about that, but it has been so wonderful to discover your writing about ADHD in the compassion, through the compassion lens, because of course it resonates with MBT, and that's how we started working together as well. That's another thing that connected us. But I was profoundly touched to hear how you went to school and the role of your grandmother in that, and to hear the powerful oratory voices of your own Nancy and Kirkland's, which sends cold shivers down my spine and reminds me of Nelson Mandela and Desmond Tutu, and this idea of everyone having a place in the Rainbow Nation. ADHD, people of all colors, and how to make sure that everyone is represented and has a voice and is welcomed into the community. I think we experience the same issue in Canadian academic institutions. And we have when I see my colleagues, I say to them, we have to be inclusive, we have to change. We cannot stay the same and welcome people, like you said, first generation academics, sometimes, or young students whose parents did not go to university. We have to change, but we will enrich our academic institutions. We won't lose something. We will gain something that's much bigger than what we will be changing or losing. So I just wanted to start by saying I really resonate with that, putting that forefront onto the agenda. While of course I cannot speak on behalf of a community that I do not represent or belong to, but I'm very, very moved when I hear your experience and the work you've done on advancing that. Francine, when you spoke about your son, I also thought of my son, because I think he could have very easily have gotten a diagnosis. And thank heavens we live 5 minutes from the school, because the number of times I've had to take lunch boxes and basketball clothes and history book, and I can't count. But the one thing that strikes me as well is how people change over time, and how without medication, young people can change and integrate ADHD and find ways of living with it. And I have a colleague at our university who has done a longitudinal study on people with ADHD, and she has the highest, for longitudinal work, the highest response rate. These people don't drop out. So it says to me that there's something very, 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 very capable and strong, saying, what do we have, and what can we do about that? And I wondered whether you have, what your experience is with regard to ADHD growing up, in a way, if I can put it that way.
Yeah, thank you for saying that, and for your kind words, Karen. You know, with one of the things that's interesting to me, and we've sort of witnessed in the Compassion Project, is that often we have to make calls to, you know, I don't know what it is in Canada, but it's the child welfare system. And because we're taking a mentalizing approach with the parents, we sit them down, we explain what the law is, why we have to make the call. We can imagine what it feels like for the parent. We can imagine how, you know, afraid they may feel, or anxious, or what have you. But we have that conversation before we make the call, and then we make the call together. And I think that's what I mean about like compassion. That's what I mean about sort of the power of this approach. And most of the time, the parents continue treatment. And that, I think, is, you know, sort of what resonates with me when you were talking about the dropout, low dropout rate, is that there is so much commitment and curiosity about this particular way in which the mind works, and people want to understand it. And it's only recently that the DSM actually included an adult category. And, it's kind of like, oh, so by the time they go from 18 to 19 or 21 to 22, their psyche is the same. It doesn't change in a way. They become better at regulating, better at following through, better at managing themselves or picking environments in which they can thrive. But, their challenges don't go away. And so I was really surprised by that, by the commitment of the parents to keep working it through, even when this could potentially be a deal breaker for a parent. It's like you're being, called.
Yes.
Yeah.
Yes.
Thank you so much, Karen. I'm trying to be mindful of our time and making sure we get enough time for audiences to comment and have questions. And thank you, Karen, and thank you, Francine, for this discussion. And it's enriched us all in many ways. Before we go to the audience, I'm going to squeeze in my question that I was holding on to from earlier, which I've also asked Kirkland. But when we go through psychodynamic training, we're exposed to a lot of ideas, some excellent ideas and some not so excellent ideas. And I am curious about, from your training, what are the ideas that you still hold on to that are incredibly meaningful to you and to the work you're doing? And what might be ideas that you've said, yeah, that just doesn't work for me?
I think a couple of things. This idea of meeting the child where they're at is a very sort of psychodynamic-esque concept that works. I think that works completely with this idea of compassion. One of the ways in which Karen had explained it to the students is kind of like a squiggle, where you're sort of joined in this way and you're kind of going back and forth and you're flowing together and you're using your curiosity to sort of get a deeper understanding of the child. So that part works very well for me. It works very well in this model, of using MBTC to work with children with ADHD. What doesn't work for me as well is sort of the rigidity of, if I remember being a young clinician and was told by my supervisor, if the client misses 3 sessions, they're out. That's it. They're resistant. They don't want treatment. They're treatment resistant, so on and so forth. That doesn't work for me because I understand that I have to make a living and that, it's important for clients to show up. But the conversation that you have with a client and your understanding of why they haven't shown up, and Kirkland sort of alluded to this, which is, work demands. Sometimes they're the only parent. Sometimes they themselves are struggling with some of the very same issues that their child is struggling with. So this idea of keeping the frame, not reaching out to the parent in between sessions, waiting to bring whatever issue there is to the therapeutic hour just doesn't work with a lot of, especially ADHD parents who are, struggling to keep things organized and keep things moving forward. And it doesn't work for the different culture groups as well, because if a parent calls you to say, okay, you hear them out and say, okay, we'll discuss it when I see you next week. That just doesn't work for me.
Thank you so much. And we will have Kirkland with us by the end of the year, so we will ask him that same question because he had a lot to say about that as well. So thanks, Francine. I'm keeping track of, from all our interviewees, what they've held on to and what they've let go of. Maybe we'll have a paper out of it. there's an interesting question in the chat because I think it really speaks directly to the type of work you've been doing because there's so much going on in the chat. I'm just having a hard time. It keeps scrolling. Do you have that?
Yeah, no, I was just going to say there's a lovely tribute to Francine from Amy Vigliotti. Francine mentored me during my doctoral years at Derna. She was extremely influential in my decision to become a child psychologist, and I'm forever grateful. I knew there would be so much gained during this talk today. Thank you. Compassionately embracing the parents' fears and oftentimes the real life threats and stresses is such an important and helpful reminder in the treatment of the child with ADHD and or other issues.
Wonderful. I found a question. It's from Raj Nadir. I hope I'm saying that correctly. But it's how can this model work in a time where money talks and resources are low and session numbers are reduced to as few as 6 to 10?
Well, that's great because the model that I adopted from Karen is a 12-week treatment. And so it is short term. It is using the mentalization-based child treatment protocol. And it's been working so far. I mean, it's really been impressive. So 12-week session, that's it. We start with the parent and the child in the first session. By session 6, we're doing parent and child again. And then at the end, the session 12, parent and child. And then we follow up 6 months later just to get a sense of where things are. Are they maintaining their gains and so on? So far it's been interesting, and we'll see when I have enough data to kind of publish a report on it. But yeah.
It's interesting, Francine, because obviously when we do psychodynamic treatment, we're thinking of it being more long-term than that. And so what are the things that are accomplished in 12 sessions, and what are the things that you really can't get to in 12 sessions and really need a more extended treatment to get to?
Sure. So the 12 session model, and Karen, you can jump in here, but one of the things we do, it's very, I wouldn't say it's structured. I would say that it has a frame. And so early on in the session, you're trying to get a focus formulation about this child. And so some examples are things like this one child said that he's like a runaway train, or another child would say he's, like you mentioned, the Hulk or superhero or what have you. And so you've got that metaphor now that you can use with the parents and with the child and start to really identify, the times when they are a runaway train and the times when they're parked and how it, plays back and forth. And because we see the client, the patient, the child in once a week. We also see the parents once a week. So it's together. So in all, it's about 24 sessions, and then we have sort of the joint sessions where we evaluate. And the other thing is the focus of the treatment is not on the behavior. It's how do we build the relationship between the child and the parent? How do we develop reflective capacity, which Karen writes a lot about, in the child? How do we develop it in the parent? And so it's a very focused work. And yes, there's lots more that we can do, but that's the point of this particular project that we're working on.
Maybe just to add, it's also to help the child to begin to tell their story, to be able to scaffold the story-making capacity, to be able to not focus on behavior and ADHD, but having a voice in the play and linking it together so that she can have a beginning, a middle, and an end to a story, which they can often not do by themselves.
We've got some more comments here on the chat, which I'd like to share with you. Iris Gibbs says, thank you, Francine, for your comment that Black professionals also need encouragement and acceptance. It can be a very lonely journey at times. This interesting comment here from Susan Warshaw. talking about the concept of nested mentalization, saying that there's some interesting work going on there, which I think originated with the work of Arietta Slade. And Kirkland's nodding because I remember speaking with you about this. I think this is something that you're very keen on as well, particularly in schools. Do you want to say some more about that, Kirkland, and perhaps Francine, if you want to come in as well? You need to unmute.
I'll jump in. So when we started this project, we actually, we have a school psychology program at Gazette, and we wanted to help not only the child, and we had our students working in the schools, not only with the child, but also with the teacher. And I love this concept because it's sort of, helping the supervisor help the student reflect on their own emotional reaction and growth. And so it's layered, and I guess nested is the perfect word. We have more work to do in that way. I find that the teachers do want support. They do also want to feel understood. They do also want to be recognized for all the efforts that they're doing in trying to help this child. And so it's kind of like nested. It's this perfect word for it. So,
Kirkland, you are muted now. You can come in.
I'm okay. Good. I agree with Warshaw and with Conway. I love this notion of nested supervision, but I think really its origin is African. But I won't get into that debate right now. Okay?
You can ask something about that. It's very interesting.
Nested supervision comes from a mentality that's a collective mentality, not an individual mentality, and that's what Nancy was speaking to earlier. And I also believe it is so powerful that we focus in on the symptoms of the child, which Francine has been telling us to go away from, and we need to focus more on the actual supervision. So that here's a student working under conditions that he or she is not being trained for, and we're saying to them, mentalize this child, when in fact the therapist is not being mentalized by the very institution that has him or her there, or they there. And so I think that it's a very powerful concept that can alter really the course of treatment in and out of itself, because it provides a holding for the therapist so he or she or they can do their work and feel understood, as opposed to what Conway was saying earlier. The therapist feels so threatened by their own countertransference, 1, 2, not being successful. So all of that is being held by the institution who holds the therapist, so the therapist can hold the patient. For me, it's a complete flip around. I will argue to the day I die, it's African in origin. I'm glad for Arietta Slade. I love her, and she's brilliant. So, but I think it's African in origin. Just like I see Winnicott as African in origin when he says it's about they. But I'm not going to go there today. I promise I wouldn't go there. Okay.
Even though he's enough.
Fran mentioned earlier the parallel process, and that I would argue Kirkland is also African, but we won't in origin.
And I think also, I agree with Arietta. It's like I remember being a young doctoral student and not wanting my supervisors to actually know what I was really thinking about a case because it didn't feel safe. And I think what this does, it creates that safeness, that safe space where the student can really allow those emotions and those feelings and those thoughts to show up. And the supervisor can help to kind of further that sort of processing of that experience, as opposed to hiding it, which is not helpful to the client. So
you're getting lots of more accolades here, Francine. Denise says, this wonderful set of conversations about working with children and their families so lovingly reminds me of how lucky I have been in my career to have been mentored by Francine, Nancy, and Kirkland at different times. I count myself incredibly privileged, inspired to have been taught by such nuanced, sensitive, justice-oriented scholars and clinicians. Oh, wow, I'm jealous. I'm much appreciation to your organisation for creating the space for us all. Bravo, Francine. Yeah, I mean, it's got me thinking about, I am genuinely jealous that I haven't had, this sort of, this way of thinking around me as I've, been learning in my journey as a child psychotherapist. I think the people that have learned with you, Francine, Kirkland and Nancy, have been very, very lucky to be able to sort of see things from a different perspective, because I think our training, is very white oriented. It's very sort of European white oriented. And I think you've really been sort of changing things in that regard. Did you want to say something about that, Francine or Kirkland? Nancy?
I think you asked me earlier how I knew Francine. And one of the things that's very interesting is that we knew each other's work long before we knew each other, and personally. And so I think it's very important that we as clinicians, as nurses, as social workers, as teachers, reach out and pursue this kind of interaction, knowledge, learning, and not just see it as a one-time thing. I think it's very important that we reach forward and touch those who've been through it longer, but also that we put our hands back and pull the next generation of folks in our professions forward so that they don't feel this isolation. I think that's one of the things that COVID has really brought home to us, is the need to have and to purposely develop those connections. Much of my mentoring came from peers. I started in the field 50 years ago, and almost to the year. I started grad school in 1992. And we had to reach out to others to learn and to connect. And some of those individuals are still an essential part of, my world. 1972 was a very isolating time in the field. And I'm hoping that out of this discussion and Fran, your modeling of, the ways in which you've sought connection with others, I'm hoping that others on this call will be less shy about doing that with people in the field who have a lot to offer, but also with coming together in small groups to support each other when necessary, and to learn from each other. I think you've modeled that, Fran, very well.
Thank you, Nancy. I had good support. I was really, really lucky to just have the network that I have. And we don't have enough psychologists of color to go around. And so, Nancy, one of the things that you've mentioned to me is about cultural humility. And so for those who are not people of color, to kind of bring that humility to the conversation. And especially now where our country is so divided and you can't say anything because, you're going to offend someone and people are just going on the ground with their feelings and some are not. But as clinicians, as nurses, teachers, if you can also take a mentalizing stance in your interactions with people who are different from you, it can really serve to bring us all together.
Thank you very much.
Amen.
Amen, Nancy says, yes. Just a comment here from Susan Warshaw. She says that the Journal of Infant, Child and Adolescent Psychotherapy is as part of its mission in equity, diversity and inclusion. And Kirkland is president of our board of directors and was the founding editor-in-chief. And we are so proud to have had Francine Conway as our research editor over the past several years. So it's really nice. Before we wrap up, Francine, I'm wondering if you had the opportunity to talk to your younger self, that little girl growing up with her grandma in Guyana, what would you say to her?
You know, that's such an interesting question. I was so loved, and I thought I was the most precious thing to my grandmother. I thought that she valued me above all. And she's a good mentalizer, because apparently all my other cousins felt that way too. But I always maintained that I was her favorite. She loved me unconditionally, and I think it's helped to carry me through some really tough times. And so, there's not much more that I would say to that young child, because I think I was really well supported and loved and so on and so forth. But what I do is every child, Black, white, different, every young person who comes into my office, I see a future. I see a bright future. I see what they can become. I see the potential. I had this one student at Adelphi who keeps in touch with me to this day. He was my special favorite. I mean, such challenges with learning and trying to graduate. And when he graduated about a few years ago, he texted me and he said, I did it. And my grandmother was here and my family is here. And he was so happy. And this was a white male who struggled. But I didn't see that. What I saw was just a human being who was capable of connection and was smart and creative. And all that he needed was what that bench, as you guys said. And I counted a privilege to be a part of my students' lives and to provide that that confidence to give them what my grandmother gave me, which is, I am confident in you. You can do it. It may take you a little longer, or it might take you around the world a couple of times, but I believe in you. And so I'm really privileged to have the job that I have. I love it. I would not trade it for anything. So thanks for asking the question, and thank you for having me.
Thank you, Francine, and thank you from Salam and I. We really, really appreciate that hugely. You giving us this time and sharing your huge wisdom and knowledge and understanding about children. And many thanks to your invited guests, Kirkland Vaughan's, Nancy Boyd Franklin, and Karen Ensink. We're really grateful to you for sharing your experience too of working with Francine and your many insights on child and family mental health. We'd also like to say a big thank you to Laura Tennant for her help with research for today's interview. Salam and I will be in conversation again together on May the 24th, so mark your diaries, with another towering giant in child mental health, Dr. Alicia Lieberman. As director of the Child Family Research Program at the University of California, she's had a major influence on how practitioners and parents help traumatized young children. So we're really looking forward to that. And if you've loved listening to Dr. Kirkland Vaughan's today, he'll be back on the 6th of December for his turn in the Legacy Hot Seat with Salam and I. Before then, I'm delighted that I'll be in conversation with one of the UK's leading child and adolescent psychotherapists, Graham Music. He's also a board member of Mind in Mind. His book, Resparking, reconceptualizes how we should treat depression in children and adults, and he's got many ideas to respark our own practice as well. So that will be on the 15th of March. Please check out our website, where you'll find a wealth of interviews with leading clinicians like Francine, Kirkland, and Nancy, people who really are leading the way in terms of our thinking. Lots of thought pieces too to provoke your interest and make you think. And please do join us on Twitter and LinkedIn. So from all of us, thank you so much. We really enjoyed being a part of this, and I hope you have a good evening.
Thank you.
Thank you.
Bye-bye.
Bye-bye.